Hello, everyone. My name is Zachary Lane. I will be presenting today about improving lung protective strategies in the treatment of acute respiratory distress syndrome. So, for the rest of the presentation, I will be referring to acute respiratory distress syndrome as ARDS or ARDS. And what is ARDS? ARDS is one of the most challenging disease processes to treat in patient populations that encompass multiple different modalities of care to be factored in for patient outcomes. ARDS becomes challenging to treat, respiratory mechanics become stiff and difficult to ventilate without significant amounts of positive pressure. The alveolar flooding with cytokines causes the lungs to become inflamed, thus impairing oxygen distribution to the body's organs and tissues. So here's some of our lung protective strategies that we'll go over today. First being the early recognition of ARDS. Second, the open lung concept. Third, electrical impedance tomography. Fourth, esophageal manometry. And adaptive support ventilation. All these working synergistically together, we can drastically reduce mortality rates and ventilator-induced lung injuries in the patient population of ARDS. So the recognition of ARDS. So when are we seeing it? When does the patient have it? That's the most critical part with diagnosing ARDS. This also is critical to the patient's timeline to achieve positive outcomes. This time of intervention and yielding the best outcomes. Understanding the characteristics of each patient's symptoms can be complicated in ARDS. We look at the Berlin definition, which I don't really consider a definition of more like a set criteria of parameters that you'll see in ARDS. These criteria include parameters such as timing of symptoms, chest imaging, origin of edema, and oxygenation status. Um, so with the PaFO2 ratio, that's our oxygenation status. The positive pressure or partial pressure of the arterial saturation of oxygen, and then the fraction of inspired oxygen. So the amount of oxygen the patient is on. You divide those two, and you'll get a number that you can quantify as either mild, moderate, or severe hypoxemia. Also, another thing we can look at is chest imaging with X-rays and computed tomography or CT scans. You'll see bilateral opacities without effusions, lung collapse, and nodules on both X-rays and CT scans. CT scans being just a bit more detailed. So here's our standards of care. This is like the firm foundation that that's been time tested and it's worked for a long time now. Um, these are our parameters on our ventilators that we want to target, like tidal volumes of 4 to 6 mLs per kilogram. Plateau pressure is less than 30 centimeters of water pressure. Airway driving pressure is less than 15 centimeters of water pressure, and oxygen saturation greater than 92% on less than 60% of FiO2. These are all lung protective strategies that safely ventilate and oxygenate the patient. With these parameters set, we are drastically dropping mortality rates and ventilator-induced lung injuries. So this is what we just said our RTAP protocol, but now we've added an open lung concept, which the open lung concept is simply just a lung recruitment maneuver. Um, these lung recruitment maneuvers are they kind of like for a short amount of time. You've now added a driving pressure of 20, an inspiratory time at 3 seconds, an IDE ratio, which is inspiratory and expiratory ratio of 1 to 1. So as quick as you inhale, you exhale at the same time. An FiO2 of 100%, and a PEEP has increased to 25 to 30 centimeters of water pressure. So this short amount of time, we are recruiting the lung to open up the lung. We are trying to pop open all those alveoli that are consolidated and are flooded with fluid. By doing this, this result in increased lung compliance, pulmonary function, and proper PEEP titration. With the compliance is if you have a decreased compliance, your lungs are basically stiff, they're difficult to ventilate, difficult to get air in. And so as it increases, it is a lot easier to ventilate these patients. So, how we know that these patients are getting ventilated better? So we look at our CT scans. So we have to our left here some results of this study with the ARDS net 24 hours. So this is just the standard of care. No lung recruitment maneuver. And you see a lot of non-aerated lung areas or lung regions. And you go 40 hours, 48 hours later, and it is not really improved very much. So we're still very consolidated, very collapsed lung areas. But with the addition to the open lung concept or the lung recruitment maneuver, you see a drastically lower non-aerated lung regions. So we've opened up the lungs and we are ventilating and oxygenating these patients better. This is the alveolar stabilization or the open lung, thus improving PaFO2 ratios, showing that the OLC is beneficial. So with those CT scans, we were looking at the aerated lungs. Well, you have to go to radiology. So you have to take your patient from whatever room they're in, take them down to radiology, pull them over to a table, and then scan them. And that's just one scan. That's the one at that time. That's what the lung looked like. But with this technology of electrical impedance tomography, we can do CT scans almost every second. So electrical impedance tomography utilizes electrical conductivity, and it measures electrical resistivity, enabling a real-time assessment of the lung volumes and aerated lungs or lung regions. So this ultimately works by a band that wraps around the fourth and fifth intercostal space of the patient. It is attached is 16 leads with 2 positive leads that cycle around, moving in a parallel fashion, and it creates a circular image composite reading 50 times a minute. EDI utilizes a real-time individualized PEEP adjustments, improving respiratory mechanics, integration of EDI or EIT is a guiding tool for mechanical ventilation, holds potential benefits in preventing ventilator-induced lung injuries. So when we're doing those lung recruitment maneuvers, we can actually see in real time like what region that we're actually recruiting, either be distal, proximal, bilateral, and unilaterally. So this is a good way to precisely do that. PEEP, according to the lung physiology, to achieve better pulmonary function, can reduce the need for higher levels of PEEP. PEEP being positive end expiratory pressure. So PEEP is what we use to keep these alveoli open, the other lung regions open. So with the application of that, we can recruit these lungs and keep them open and ventilated and oxygenated. So if you see in this image here, you have a set PEEP of 10, and you see blue is good, white's even better possibly. And then you have this gray dark area at the bottom. As we start to increase our PEEP, we see a fully aerated lung. And these are all images made by EIT. So very useful tool. Another useful tool that we can use is esophageal manometry. This is the application or insertion of the esophageal balloon down into the patient's esophagus. This is also to track or measure the patient's respiratory mechanics through pulmonary pressures, transpulmonary pressures. So you see here's our breathing tube, it goes into our lungs, and then here is our esophageal balloon inserted into the esophagus, because this is our stomach, here's our diaphragm, and our lungs. And as the lungs fill and exhale, it applies pressure onto the chest wall and onto the esophagus. That's where we get our measurements. So with the application of esophageal balloon, like I said, we were measuring our compliance and our pressures through transpulmonary pressures. Targeting 0 centimeters of water pressure in expiratory transpulmonary pressure is what we want to minimize our mortality rate. So by targeting 0 centimeters of water pressure, we will reduce our mortality rates. I'll look at 2 different studies and kind of go over that now. So this is our EP Event 1 study. It was done in 2008. Had 61 patients in it. So we had 30 that received an esophageal manometer or esophageal balloon, and the other 30 getting a standards of care. We see that in the esophageal guided group, the ratio of partial pressure or PaO2 and FiO2 at 72 hours was 88 millimeters of mercury higher. So that means they were actually oxygenating better in the esophageal manometry group. And also it increased compliance a significant amount. So um, I want to point out one point here is the scaling of FiO2 to transpulmonary pressure. So you can see here on our left, the 0.4 to 0.5, that's the FiO2, had a 0 transpulmonary pressure. And even in the little bit of the upscaling of the FiO2, we're still at a minimal amount of transpulmonary pressure. Come over here to our right, we see that the esophageal guided group had a significantly lower mortality rate. And then the conventional treatment group that did not have an esophageal balloon inserted had a higher mortality rate. So this is the EP Event 2 trial. This is the, I would say the big boy trial. This is the kind of prove the EP Event 1 trials as of positive outcomes. So this is a much larger trial. Um, this is a multi-center randomized trial. Um, and so this had 202 patients in it. Um, so I think you still have this scaling of FiO2 to transpulmonary pressure, but I think because of the patient or the trial size, I think it led clinicians to not monitor the scaling of FiO2 to transpulmonary pressures as diligent as they did in the first trial. And in result with this EP-VIT2 was a negative study for esophageal manometry. We could see that because if you look at our mortality rate, here's our esophageal manometry group and our empirical high peak FiO2 table, and they're almost the same. So the conclusions was among patients with a moderate severe ARDS, compared to the high peak FiO2, resulted in no significant difference in days or death free from mechanical ventilation. Which is strange because the first study was so successful. Um, I could be biased on this, but these like results, I feel like you're basically saying that the PEEP FiO2 table is as good as using esophageal manometry the wrong way. So during COVID, they were actually able to go back and look at the EP event and come up with a meta-analysis. So this meta-analysis kind of went through all the data, and this is actually concluded pretty fascinating results. So the effect of the survival of the pulmonary or the esophageal manometry group differed by um, multi-organ dysfunction severity, independent. Basically, this was they ended up saying that it was a positive study. Peak titration of the end-expiratory transpulmonary pressures closer to 0 was associated with greater survival than more positive than negative values. So if you go back to this last one, this was actually the negative study, with the mortality rates being about the same, and they're saying that actually if you do target that 0 transpulmonary pressure, you do have better outcomes. So lastly, we'll look at our last uh, lung protective strategy with adaptive support ventilation. So all the studies that I was looking at, patient population was focused on conventional modes of ventilation. With ASV, this is a new closed loop mode of ventilation that I believe that can be very valuable in lung protective strategies in ARDS. Adaptive support ventilation is a closed loop mode of ventilation designed and owned by Hamilton Medical. So the difference between the conventional mode and a closed loop is that the closed loop constantly communicates with the patient in the ventilator. So as the patient's mechanics change, the ventilator settings change and it adaptively works with the patient. So if you're not breathing at all, the ventilator's doing all the work. If you start breathing, the ventilator will assist you with those breaths and help you and safely ventilate you. So there's actually two key variables in the lung protective ventilation with the ASV. It uses two formulas known as the Otis formula and the Mead formula. The Otis formula is a it basically calculates the least work of breathing. Um, so it does this by the time constants of exhalation to determine the respiratory mechanics of the patient, thereby lengthening or shortening the exhalation time for the patient due basically based off the patient's compliance. ASV is set up that it will deliver 100 mLs per kilogram. So if you have a 70 ideal body weight patient, the minute ventilation will start to target 7 liters per minute. Then it will determine the optimal work of breathing, which is the Otis formula. The Mead formula is the minimal force. So this is the mechanical power applied against the lungs. This is also to optimize the ventilator-induced lung injuries. It builds a box, the ASV, so you would see on the y-axis the respiratory rates to prevent apnea and dynamic hyperinflation. To the two x-axes represent tidal volumes to prevent barotrauma, volumetrauma, and aortic distension, as well as dead space ventilation. This all is a minimal force of breathing, which it lowers driving pressures. The concept of mechanical power is recently gained attention in the probable cause of lung injury, and it incorporates not only the energy required to inflate the lung during the single breath, but also the total applied on the respiratory system. So, as previously discussed, reducing the mechanical power is expected to decrease ventilator-induced lung injury and mortality rates. So with higher levels of mechanical power are applied to the lungs, and mortality rates will increase, and hospital stays will be prolonged, and fewer ventilatory-free days are achieved. So the ASV lowers the inspiratory work and the lower respiratory rates and higher tidal volumes than the conventional. This algorithm lowers the driving pressures, which then ultimately reduces lung injury and mortality. Conclusions. So we can utilize early recognition of ARDS, open lung concept, and the ARDS-NET, and esophageal manometry, lung recruitment maneuvers, and electrical impedance tomography and adaptive support ventilation. We have established that if all these are used synergistically for diagnosing and treating ARDS, we will see lower mortality rates and ventilator-induced lung injuries, ultimately giving these patients with ARDS a better chance to return to everyday life. All right, thank you guys.